When it comes to containing costs in healthcare, everyone has their 2 cents to give. But what do those of us in the business of health insurance have to say? This is Health Sense, and I'm your host, attorney Adam Russo, CEO and co-founder of the Phia Group, a firm with over 25 years experience navigating this ever-changing industry. Join me and my guests as we make sense of effective ways to reduce the skyrocketing cost of healthcare while improving quality outcomes for patients. The only thing it will cost you is 30 minutes of your time. So let's get right to the bottom line and reimagine what healthcare could be. Hello, everybody, and welcome to Health Sense with me, your host with the most, Adam Russo, the show that gets right to the bottom line on ways to reduce healthcare costs while improving quality outcomes for patients. We are sponsored by the Phia Group, the leading cost containment firm in the country, focused on ensuring that everyone gets access to high quality and low cost care, something you just don't see. As always, please tune in at 10 a.m., 6 p.m., and 2 a.m. for you nightbirds Eastern Time on Healthcare Now Radio. So, who's our guest today? Part 5 of our 5-part episode talking about outrageous medical bills, the No Surprises Act, the IDR, and all that fun stuff that goes with it. Our guest is Scott Bennett, the Chief PRO, stands for Chief Provider Relations Officer. Welcome, Scott. How you doing, buddy?
I'm doing good. Thanks for having me for this time. Looking forward to this one.
Perfect. I'm sure you're asking, folks, what is the word of the day? Well, our word of the day today, I'm not really sure if it's a word, but it's tracks with 2 X's. TRAXX is our word of the day. You're probably wondering why. Well, you'll find out in a second. So, Scott, in our last episode, it's been great having you, bud. But we want to talk about one of the strangest and most revealing medical bills that we've looked at yet. It's not a bill for a surgery. It's not a bill for the hospital stay. It's not even a bill for the surgeon who fixed the problem. It's the bill for the people watching the nerves while the surgeon was operating. And that bill, in this case, was $94,031. If you want one story that helps explain how American medical billing can drift away from the practice of taking care of people and medicine and focus solely on the financial engineering of making as much profit on every single patient that walks in the door, then you got the case. So, Scott, tell us about this patient and what happened on this bill.
Absolutely. So this is another one of those, the bill of the month from Kaiser Health News. This is great because it's public record, it's well described, and it's well investigated. So Liv Cannon had some leg pain, and that leg pain, they really couldn't figure it out. Then she got a scan, and they discovered that it had to do with her spine. So she had spinal surgery. She went in, she got the surgery. It was very effective. It really helped her to feel better. And the surgery was covered by insurance. And then a few months later, she received this bill from Trex Medical for 4 lines that were, I think it was called diagnostic medical exams. And it was for $94,000 for intraoperative neuromonitoring. And it was an out-of-network bill. And what she said is that there was a point in the surgery where they had her sign something like at 4:30 a.m. or something like that. There might be some out-of-network charges. And she got hit with this $94,000 bill.
So everything's a success. She has the surgery. She's recuperating. I'm assuming she's maybe happier, right? Happier in her life. Things are good. And she gets this random bill months and months later, post-surgery. Now, before we go into it, you mentioned something about monitoring. What is neuromonitoring exactly? It must be really complicated stuff. $94,000. I'm assuming they put a lot of work into this.
Right. It is a clinically necessary and medical service. It's essentially when you're getting a spinal surgery or one of these really complex surgeries, the surgeon and the patient both want something that's kind of like an alarm system for your nervous system. So they hook up these electrodes and they have this system, and then someone, a clinician, a neurologist, is watching these. And if something starts to fade, well, then they can change, how they approach the surgery. They can even pause the surgery. They can make sure they don't do anything that causes permanent damage because you've got this alarm system on people's nerves.
I assume the alarm system, the monitoring ends at some point, right? What's the beginning and what's the end? Is the beginning of this monitoring right before surgery and it ends once the surgery's over? How does that work?
the monitoring and the hookup is during the surgery. That's the
Okay.
idea, is to watch it during the surgery. So it essentially maps pretty much with the time of the surgery itself.
So it's
And
a
this
couple
one,
hours. So it's a couple hours of monitoring, whatever long
yes.
that surgery took place.
Yep, it's
Okay.
a couple hours of monitoring. And to dig into this bill, we've got the 4 lines. A big caveat on this one is the health news article didn't publish an itemized bill. So that's one thing we always talk about is if you can get an itemized bill with the CPT codes and with the information, you can look into the coding on that. So we're going to have to make a little bit of assumptions talking about the family of codes that are typically billed. So there's 3 different ways to kind of code or bill for these surgery monitoring. One is with a CPT code that's called 95940, which is if the monitoring person is in the room. So that's one. The next is that remote one. If the person is remote, 95941, and
Okay.
that's remote, it can be billed in hourly increments. And it's either you're watching it remotely or you're in the room, but monitoring multiple cases.
So you're in that room, but you also are monitoring 3 other people's surgeries at the same time.
Right. Yep. So that's
Okay.
multi-case and remote is that code. And then Medicare came up with another code, GO453. And that code wanted to make sure that if people are monitoring remotely, that they're focused expressly on that one patient, that specific patient. So this is really
Okay.
good information to know if you can get the coding information, or if you're just getting asked or talked to about a surgery, to be able to say, well, wait a minute, is this going to be remote monitoring? Because if it is remote monitoring, and then how's it going to be billed? At least you'll have an understanding of the services that we're going to be provided.
So far, just so all the listeners understand, we have 3 different codes. One code is timed for 15 minutes. The second one is tied to an hour of monitoring. And the third one is Medicare's attempt to basically fence off exclusive one-on-one patient attention. Already, I could see games being played in regards to
Right.
how you bill depending on that monitoring situation.
Yes, you're absolutely right. This is a time-based code. So there's potential for abuse on calculating the time correctly, like you said, with the surgery and how much time is billed. There's different modalities. So whether it's remote, whether it's multiple cases, and there's just a lot of area for ambiguity on how these are coded. And that's an issue. But in this situation, we don't have that data. It's a very broad, and this is one of the issues is when there's hidden information, that sometimes is where that strategic and financial leverage sits, is in not having the codes or not having the information. So that was a problem with this, that it's just 4 lines of medical diagnostic exam. But any way you cut this, any way you look at it, $94,000 for this amount is an inflated charge. And I'm not just saying this, as my opinion. The article had the president of the Neurologists Society I think it's Society of Professional Neuromonitoring.
Actually, Scott, it's the American Society of Neurophysiological Monitoring. They must have some cool parties, huh?
I definitely imagine it. No kidding. Well, if they're billing 94,000 for their services, then
It's
they've got the
caviar and
funds.
champagne.
Yeah, no kidding. Anyway, but that society actually condemned these charges. They said there's no way you can justify these charges. But then in the interview, they went on to say a little bit more, that one of the issues that they have in the past spoken out against is that there are financial incentives in referring cases. So the money isn't just going for the professional service. The neuromonitoring company wants to provide the technical support for this. And so they're coordinating with the surgeons, and then there's money flowing around. So there's that issue.
So you're telling me there's steerage between the monitoring companies and the surgeons, because the surgeons obviously control the situation, right? And I'm
Right.
assuming the surgeon decides what organization, what company they are going to work with when it comes to monitoring. They're basically, I don't want to use the word bribe, but they're giving a financial incentive back to the surgeons to utilize their firm, correct?
Right. They need cases. So you've got a neuromonitoring company that wants cases. You've got surgeons who can identify the cases, and the financial incentives can create issues because it can create overuse. And this is something the society identified. It can create overuse. It can create safety issues. It's not a good practice to have that.
So going back to this case and looking at the pricing, you mentioned Blue Cross, right? So the carrier, the insurance company,
Right.
when they looked at this bill, they allowed $815 for the bill.
Yes.
The bill
Yep.
was 94,000. I mean, that's a huge gap. It's insane. I mean, that's what makes
It
this
is.
case so important to share. How does that even happen? When the insurer allowed that, how did Blue Cross come up with that number? And then
Right.
how did the facility come up with their number?
And I imagine because it was an out-of-network service, what Blue Cross would have looked at is what is a typical reasonable payment otherwise. And so when you look at the this one said that it was several hours, so it's a couple $100 per hour, and we can't tell specifically whether or not that bill is the professional and the technical component, the hooking up of the diodes and that sort of thing, as well as the professional. But let's assume it's just the professional component. It's just the time spent performing the monitoring, and a couple $100 an hour is a common amount for these sorts of cares that's paid. And sometimes it's a common amount that's billed. I looked up the data because there's public data that shows you for specific codes. And I looked up the GO 453 in the Medicare data. And a lot of the surgeons, I think it was, well over 10 that I saw in Texas, they're billing an average of, 100 or a couple $100 an hour for this.
And before, we get too far, it's important to note, I could see somebody listening going, that big bad insurance company, how could they only pay a few $100 for this? The bottom line is, in this particular situation, the Blue Cross covered and paid all the other big bills associated with the surgery. It was just this one monitoring piece that they limited the amount that they would reimburse. Is that correct?
Yes. The rest of the surgeries were covered. It was copays, standard in-network stuff. And this was that surprise out-of-network bill. I'll say again, this is one that happened in 2017. It was before the No Surprises Act. But that creates the kind of conflict that isn't not just an argument over $900 versus $2,000 or something like that. This is two entirely different value systems and models. One is paying a reasonable amount that covers and provides a little bit of profit for the healthcare service. The other is a business model where you charge in an out-of-network situation absolutely as much as you can to anchor and receive the highest amount possible. And balance billing used to be the leverage for getting there.
So I'm assuming the patient in this particular case was told, hey, we know you went to an in-network hospital. You have an in-network surgeon, right? So that's why you have insurance. However, this monitoring piece is not in-network, and therefore you might be subject to having to pay, a balance bill. I'm assuming that's what she was signing at 4:30 in the morning, correct?
Right. I wouldn't say that counts as really an opportunity to make an informed decision. And I think she identified in the article that it was just, let's get this done. I'm here for the surgery. Is she really going to say, no, I don't want remote monitoring, or I'm denying or rejecting this service? You trust the clinical people in there. And that's one thing the article brought up, is that there should have been more information and more preparation and more of an understanding. And she should have had the opportunity to say, is this in network? Is it going to be remote monitoring? Is the monitoring going to be in the facility? All the questions that would have identified a way to protect herself financially.
Right. But again, she's going in for surgery. That's the last thing on her mind.
Right.
And it seems like the system is built to take advantage of people in these situations because of that fact, right? I mean, it isn't like she's going out buying a car where she can change her mind and decide to come back to the dealership or go somewhere else. If you're just joining us, today's guest is Scott Bennett, the Chief Provider Relations Officer at the Phia Group, and we are doing part 5 of our 5-part special series on outrageous hospital bills and the No Surprises Act. But let's get a little technical. How much time professionally are we talking about when it comes to a spinal surgery like this? Knock on wood, I've never had one. I don't have a friend that's had one, but how complex is this, and how long does a surgery like this typically take?
The article said several hours. So it's absolutely a several-hour surgery, and the monitoring would have been clinically necessary. But even though, you ask how much time and what goes into, specifically identifying, closure and when devices are put in, that whole sort of thing, none of that justifies the amount of the inflation associated with this price. It's just not, for those services, something that can be connected. And that was supported by the society itself identifying it.
So the bottom line is, it was necessary. We have to monitor.
Right.
That's not the question. So it could be, this isn't a situation where the claim was denied because it wasn't medically necessary. It definitely was. Mm-hmm. Except the charges were just extremely offensive and outrageous. They weren't reasonable in this situation.
Yeah, clinically necessary, but financially it was way too much, and it just shows a business model that wasn't sustainable, and it's what brought all of the concerns. And this article is one of those articles that brought the concerns about protecting patients.
So because there was so little information as it relates to what type of monitoring was done, right? Was it exclusive one-on-one monitoring? Were they sharing a bunch of patients? Was it in the room? Was it remote? There's a lot of information that's not there. Was
Right.
that information given to the patient when they received that balance bill? Did they dig for that information and then eventually get it? What's the story behind that?
Nothing indicates they followed that kind of standard practice we've been talking about of requesting the itemized bill, requesting the HICFA, as it's called, the professional bill with the CPT codes on it and the units on it, and better descriptions, or even a narrative of what occurred, and also identifying in this situation the professional and the technical component, because you're not allowed to bill for the technical component under the professional codes, and so there's a lot to be reviewed there. And I would say, you bring up a good point. Requesting that is a very good first step, not just trusting that whatever piece of paper you get with statements like for diagnostic medical exams is the right way to go.
Right. But you mentioned earlier, this all happened in 2017, I believe. And that
Yes.
was before the No Surprises Act was enacted. So I'm assuming the same facts, the same situation, we wouldn't have a problem today, correct?
And now we're getting into No Surprises Act. So neuromonitoring was one of the key surprise types of bill. Assistant surgeons in neuromonitoring, right? This
Right.
assistant surgeon shows up, and all of a sudden there's a humongous assistant surgeon bill out of network. Nobody knew about it.
Yep.
Neuromonitoring, even sort of more sinister feeling because it's just somebody out there when you're getting this surgery that's watching and charging a lot of amount. So the NSA protected patients. You're right. This happens under the No Surprises Act, and the patient pays their copay, and they're at it. But what it does is it just shifts it slightly further to, in a lot of instances, the self-funded employer and the plan, whether it's
Right.
a carrier or a plan, and the plan is then responsible for handling this and we've talked about it in a number of episodes, through that independent dispute resolution process, IDR, and open negotiations under the NSA to determine what the amount is to be paid.
However, if I'm the patient, right, again, I'm not looking at long term. I'm not looking at how these bills and the outrageous bills are going to affect next year's premium or next year's deductibles or 5 years from now. If you're the patient, before the NSA, you're getting balance billed 95 grand.
Mm-hmm.
After the NSA, there's no noise. There's no balance bill. So from the patient's perspective, this all worked out perfectly when it comes to the NSA. Wow, this is great. I'm not being balance billed. But what you're telling us is what?
Is that it may seem in the instance that immediate harm was avoided, but
Yes.
every single employee on that plan, and this is theoretical, but every single employee in that plan is going to pay 15% more in their premiums. So that's money, that's grocery money, that's money from the, how they're going to live. Everybody pays that amount. Premiums go up. Insurance goes, stop loss insurance goes up. There's an increase in cost that is borne. Employers, because especially employers that are self-funded, may not be able to hire. They may have to make serious financial decisions based on these surprise bills that hit them and hit their bottom line and really affect their budgets.
So it goes back to, the intent of Congress, right? Or the government. When we looked at, Obamacare as an example, people refer it like that to, PPACA, as I like to call it.
Mm-hmm.
It was all about, let's make sure everyone has insurance and let's not focus on ways to actually reduce cost. In this situation, okay, let's find a way to resolve these balance bills that patients are being ruined, having their credit ruined. They can't buy a house. They can't refi, et cetera, et cetera.
Right.
But nothing was done about, well, let's find a way to make sure that these bills are being reasonable in the first place, and that insurance companies, self-funded employers, et cetera, aren't being overcharged, because that will lead to higher premiums, and that hurts everybody. Okay, makes a lot of sense to me. So in this case, right, we talked about it would have gone to, I assume, it would be an NSA claim, where potentially it would go to an IDR situation, independent dispute resolution situation, because I'm assuming the facility would not have wanted to try in good faith to negotiate a deal within the first 30 days.
Right.
So this case goes to IDR. And in that situation, as you mentioned in previous episodes, you might end up paying $180,000 on this bill, right?
Yes. And there's evidence in IDR right now, at least, that this process is not achieving the results that they hope. It's as we said, it's not a reasonable conversation about whether something is $800 or $1,200. They're coming in claims like this. You're coming in with evidence where this baseball style arbitration of two offers is $800 with some evidentiary support and $94,000. And what is most concerning is that 90% of the initiated IDR disputes are resolved in favor of the provider. They select their amount. So it's very possible that $94,000 would have been selected as the payment amount for the employer in a determination in this situation. And it's because that is strategic. Now, there's some additional data on who's actually initiating these. Okay, go ahead.
So before we get into who, right? I'm looking at this as an investor myself, right? I'd like to invest. So I'm looking at this situation, and you just told me 90% of the time the providers are winning. How do I get into that game? How do I get in the game as an investor? And I'm looking at private equity, I'm assuming, or other organizations where you could actually benefit from this 90-10 split that's currently across our country where we don't see any end in sight. And I'm assuming that's where these private equity firms and special companies come into play to take advantage of this situation.
Yes, it's an environment that has created incentives to have a strategic revenue engine. And that's what, at least luckily, that is starting to be reported on, and they're starting to be documented. We talked about a bill. Now we can look at some articles and even a lawsuit that's showing that exactly what you said, those incentives and that environment was created, and they built it, and now they have come. And so there are companies that are specifically focused on acting on behalf of providers.
Could you give us an example of a company and maybe
share
a story on?
Well, there's 3 companies, but we'll focus on one. There was an article recently that said, look, 44% of the IDR disputes recently filed came from HaloMD, SCP, and Team Health. 3 entities, 44% of the disputes, humongous backlog on these disputes and unbelievable leverage. And so HaloMD is one of them there's a stat news article that focused on it and identified what their process was. And what's interesting about HaloMD, and it's why it ties well into this bill, is the ownership of HaloMD has a relationship with and had neuromonitoring as one of its previous activities. So it was something called Empower Health. There's relationships in the ownership, and Empower Health was one of those neuromonitoring companies that had arrangements with surgeons to go in and bill and leverage balance billing and significant charges for this. And so it's just shifted. And now that company, HaloMD, is filing on disputes and initiating open negotiations and disputes on everything they can at very high numbers.
And how much are they winning on average?
On average, they're getting 9 times. And these are from the federal reports. I'm just repeating what the articles in the federal reports show. 9 times the median commercial rate.
Crazy. So you're telling me what they're getting after going through the process is almost 10 times what an in-network rate would be. Yep. So to give people perspective, something that would cost you in-network at $1,000, they're getting awarded. They're not billing this. They're being awarded at least $9,000.
Yeah, and the other issue on it is that isn't even capped in balance billing. At very least, it was capped at the billed charge. That was something that existed. And now these IDR offers, because the regulation intended to say you can't just give people billed charges, you can't consider billed charges, that's been turned on its head. And because you can't consider it, they are making offers above billed charges to receiving those amounts. So they're going in, and what an incentive for a company to be able to say, look, we can collect for you. We can collect up to 9 times what you're getting commercially in network or what you could have been, and we're going to win 90% of the time, and we can ask for money above your billed charges.
So I'm assuming something is being done about this legislatively, or is there lawsuits? I mean, where are we right now when it comes to business practice or incentives or just highest revenue potential strategies that organizations like HaloMD and STAT are doing? What's going on out there to combat this? Anything?
Well, first, the employers are becoming more sophisticated. They're responding. They're actively communicating with the IDREs, and that's getting some success, moderate, but we're still seeing a lot of the wins. But also, yes, there are lawsuits. Anthem has sued HaloMD, and there's a public lawsuit. And the STAT article, investigative article, and the lawsuit both identify that they're filing or initiating on over 50% of the disputes aren't even eligible. So this is where they're initiating disputes that are clearly ineligible.
So we're talking about first, you're not even talking about excessive charges. You're talking about bills that aren't covered at all.
Right. Not covered, or they aren't eligible for the NSA. So they're either for some technical reason, they're in network, or it's out of network facility, out of network neuromonitoring. So it doesn't even classify for the criteria for the NSA.
So bottom line is, you're telling me, I mean, I remember, again, I'm going to sound like an old person. I remember when hospitals and facilities used to fight and say, well, this is in network. Because it's in network, you have no right to audit. You have no right to review. You have no right to negotiate. You pay the in-network rate, whether it's 20% off bill charges, etc. But at least you knew the most you're going to pay is that bill charge amount. You're telling me now half of the submissions that are going into the NSA process that these claims aren't even out-of-network claims eligible for the NSA. They're just in-network claims.
Yep, they're either, it's the criteria, either they're in-network claims or they're not out-of-network professional claims at an in-network facility. So they're just initiating them. They're getting determinations, and that's why Aetna has filed a suit, is because it's so many and such an aggressive policy that they're not able to prevent them in the dispute, and they already have these determinations, which are very difficult to unwind.
It's amazing to think about the shift, right? Going from years of we're in-network, pay us the rate, to trying to find ways to become out of network, to take advantage of these loopholes and these arbitration decisions that could give them a massive windfall. So let's end this, because it's been great so far. Great information, wild story. What should the listeners of this show, and especially this episode, take away from all of this? What are the practical lessons here?
Yep. Well, as we always say, always ask for as much detail as you can get on your bills to understand them. And then in this one, in neuromonitoring specifically, if you're going to get a surgery that's going to require this, like a spinal surgery or something like that, be sure to ask about whether or not there's a risk of this being out of network. And then lastly, for employers and benefit consultants, really pay attention. This isn't just static. This isn't just something that's happened. This is going to be a large part of your trend. And so understand whether or not there's strategy in your area that you need to address and be ready for it. But really, the idea is just be more mindful about this. Pay close attention to the dollars and cents that are happening in your healthcare.
And there it is. I have one image I'm going to leave people with, is this. You have a surgeon in the operating room trying to protect the spinal cord. You have the monitoring company claiming it's being protecting the nerves, right? Watching all this. The insurer allowed $815 for the monitoring. A bill comes in for $94,000, and our system doesn't do anything about it. In our current world, this is what we call healthcare. And this is why we have exorbitant bills, costs that won't go down, and expectation that next year, just like Einstein said, nothing's going to be different. We're going to have increased premiums, increased copays, increase in the out-of-network utilization. But that's our healthcare system. Too bad.
Yeah, no kidding.
Well, listen, Scott, it's been a pleasure. I'm sure you're ready to get rid of me and not have to deal with this anymore.
This has been great.
Absolutely awesome working with you. And thank you for educating me, and thank you for educating our listeners. Folks, that's all the time we have for today. I want to thank Scott Bennett Group for joining us here today. And as always, I'm going to change it up this time because spring training's right here. Let's go, Cleveland Guardians. Have a great day.